Okay, this is Tumor Video 2, and we're starting with causes of cancer. The most prevalent accepted causes of cancer today would be the carcinogens, radiation, viruses, hereditary. Carcinogens, radiation, viruses, hereditary. Then, of course, there are times when we just don't know. Carcinogen is a substance that can generate a cancer. It can be various different substances. We always find it new. You'll see in the news or the literature, this, if you take this will cause cancer and so forth like that. Even they found food cooking, certain food being cooked at high temperatures sometimes can convert. Tobacco smoke, well, we definitely know that. Even working different hours has been associated. Here's a list, and don't try to learn it, of some of the carcinogens that we found as of a few years back, just to show you. But these are substances in the environment created artificially or naturally sometimes that can cause cancer associated. All of this has to do, though, when you look with a statistical association. It doesn't say, let me be real honest, if you take arsenic, you will get cancer. Like arsenic is one of the things. It doesn't say that. What it is statistically associated. There's a higher incidence of a person associated with one of these substances having cancer, but it is not a 100%. It's just a slightly higher elevation than the general population. Certain viruses. See, a virus, when you get into micro, you'll learn more, but a virus has to incorporate into your DNA. And if it happens to incorporate into one of those proto-oncogenes, think about it. It could cause a mutation of those proto-oncogenes or of a tumor suppressor gene. Viruses have a very specific place that their enzymes cut in. So that's why that the human papillomavirus, because viruses have specificity as to what area of the DNA they will enter into. So the human papillomavirus, which causes warts, is associated with cervical cancer, higher incidence, Epstein-Barr, Burkitt's lymphoma. So there are certain viruses that are also associated with an increased incidence of cancer. Hereditary. There's no real strong hereditary, that cancer can be passed on, but there are slight increases in above the normal population that you see. Most of these have to do with genes that deal with enzymes or hormones that could influence it. Breast cancer has some hereditary predisposition again. For example, a woman who has a first-degree relative, such as a mother, with breast cancer is about twice as likely to develop breast cancer. Colon cancer somewhat also. Retinoblastoma. So that's why when you go to a physician or a nurse practitioner, a physician assistant, that in our workup we will ask, has anybody in your family ever had this, that, or so forth like that, to try to get an idea on certain conditions, not just cancer, even hypertension and other things. What are some of the cancer preventives that we have? Well, minimize exposure to carcinogen. Antioxidants. Now, oxidation and inflammation now are moving up on the list of being possible causes of cancer. Remember we talked about oxidants, free radicals. So free radicals can attack into the DNA and potentially cause that. So that's why some suggest dietary antioxidants. And then, of course, regular medical checkups. Now, if you did have a tumor, let's say, for example, let's do it this way. Let's say a female comes in and she has a lump. The physician does a check and finds a lump. Then he says, I certainly would like to biopsy that. Okay? This was found on a routine physical exam. So he does a biopsy of it, And from the biopsy, it comes back if it's benign, other words, determine the cell type. But first thing, and I should back up, which I don't have here. The first thing with the biopsy would be, is it benign or malignant? So let's go back again. Let me start it before even this slide. Lady comes in, routine exam. The physician feels a lump in the breast. He says, this is interesting. Or you see it on a mammogram. So then the physician says, I would love to biopsy this. So he gets a biopsy, and step one would really be to find out if it's benign or malignant. If it's benign, then the physician may take it out or may leave it there and just watch it and on routine exams. So that's that. Now, this slide here then would start if it's found to be malignant. So now we're starting here. So now once it's found to be malignant, then we want to find the cell type, the grade, and the stage. These three things. Why? Because that's how we deal with the treatment. Is determine what treatment would be determined by this. Okay, you had 210 different cell types, but we want to know what is the cell type. So under the microscope, the person looking at it, pathologist, would say the cell type. He would also give what we call the grade. Some call this the histologic grade. The grade determines how bizarre do the cells look. Now remember, when you're doing rapid mitosis, you don't spend much time in that first part of the cell divisional cycle. So the more bizarre the cells look, the less time that they're spending in G1. Let me say it again. The more bizarre the cells look, the less time in G1, which means it's a rapidly growing, rapidly multiplying tumor. The stage takes a while. The stage is how far has the cancer spread at this very moment. So that's when you have to look at other areas of the body. Remember metastasis. Okay. So the grading of a tumor, you can read this, is how bizarre it looks. Generally, it's graded from a 1 to 4. A 1 is a very low grade. If you put words with it, we'll generally say, let's see here. Generally, if we put words with it, we'll say it is a cancer, but it's well differentiated, low grade. That means it is spending some time in G1 and getting a chance to do some differentiation. A little faster growth, moderately differentiated, spending less time in G1. Grade 3, poorly differentiated, hardly spend any time. And grade 4, very poorly or anaplastic. This is the worst. So that's the grading. The grading, the cell type look and the grading are done under the microscope. So you'll have attained a biopsy and you would have looked under the microscope, or at least the pathologist would have. The staging is how far has the cancer already spread when we found it. A stage 1 generally, and then they have subtypes like a 1, a 1A, a 1B, but I'm not getting into all that. But a 1 generally is in the same location. It's in the primary site. Then as you start going further than that, it is further out. So a stage 4 is generally all over the body. So if a person comes in and unfortunately they have a tumor, and you find it a grade 4, very, very, very poorly differentiated, and a stage 4 all over the body, the likelihood of them surviving, a month, is probably very poor. Again, depending on the type of tumor. Not to say that those have not come back from that. I'm not going to say it hadn't, but it's very unlikely. What are some of the cancer treatments we have? Surgery, chemotherapy, radiation, hormonal. Most time it's a multi-approach. Surgery, when it comes to surgery, you can do a total excision, a partial excision, debulking, vascular ablation. Okay, what does that mean? If you can take the whole thing out, you will. But when you take it out, and in surgery, you send it to the path lab, and you're looking for what we call free margins, which means that when you took it out, you took more of an area out than just the tumor, so the margins are free. That means the tumor has not spread past that line. Now, I'm going to be very honest with you. That doesn't mean that it's not, that it didn't spread. It may have skipped over that area and gone. So that's the total excision. Partial excision, you can't take it all out. You're taking some of it out and then following up with another treatment. Debulking is just to get rid of the mass to try to assist in either doing another treatment or relieving pain. And then vascular ablation is where you try to cut the blood vessels to it. Okay? And we won't get into all that. Cryosurgery is a cold surgery therapy. Laser. Chemotherapy, chemotherapeutic agents attempt to slow down mitosis pretty much in all rapidly mitosing cells within your body when you're on chemo. Now, what are rapidly mitosing cells in the body under normally? Your blood cells, your skin, your hair. That's why when a person's on chemo, even though it's targeted for one thing, oftentimes a person will lose hair, skin will get thinner, their blood count will go down. So if we schedule you, let's say, for chemo on a Friday, you'd come in either that Friday morning or that Thursday evening, generally that Friday morning. They do a blood count real quick to see what your count is. If it's too low, they'd say we have to reschedule, because you can't help one person on one end and hurt them on the other end. So that's chemotherapy. There are various types of chemotherapeutic agents that we have. And you can glance at it. Again, don't get very heavy into this. I just wanted to kind of introduce a little pathology to you. Radiation therapy is done by a radiation oncologist. It's generally not done by the same doctor. A physician that is a cancer doctor is an oncologist. So let's say in gynecology, we have what we call gynecologic oncologists. But the person that does radiation has been trained in a different area. They're generally a modified radiologist that's done extra training, and they're called a radiation oncologist. And you're sent there. And what they try to do is find out the best spot to put the radiation in order to attempt to fight the cancer. Okay, that's radiation therapy. Hormonal therapy is used for tumors that have a hormonal action, like the ovary. Just take, for example, the ovary and the testes in males. So if you had a testicular cancer, you may be fought with something that's more female hormone to ablate it. Females may be fought with more male hormones. So again, you can glance at that. Don't get too heavy. Here's hormonal treatment for prostate. Here's the new big one coming up, cancer immunotherapy. In that particular case, what you're doing is you are taking antibodies and modifying them. This is in medicine, and trying to make them go for the tumor cells, trying to make them go for the tumor cells. So this is a new emerging field that seems to be to try to get your body to do what it can do. Okay. Hyperthermia is another treatment. Okay. Keytruda is a new one. It blocks you see that on TV a lot. It protects mechanisms on cancer cells and allow the immune system to destroy these cells. Gene therapy is a new way that we're getting very heavy off into. So these are some various treatments. And of course, if things can't work, then pain management, palliative treatment, that means treating the symptoms. Alternative treatments. So again, but the treatment type depends on us. The most determining what is your cell type, grade, and stage. And then from that, clinical studies will say what will be the best treatment. Clinical studies will say what will be the best treatment for that, unless it's 100% curable. Thank you.